All right, good morning everyone and welcome to this week's Department of Medicine Grand Rounds. I'm Dana Bowen, I'm one of the chief residents here at University Hospital. Before we get started, just a few housekeeping tips. Please make sure that your videos and mics are muted during the presentation. Also, we ask that you hold your questions and comments till the end, at which time you may unmute yourselves or use the chat box to ask questions. Lastly, the CME information for today will be in the slides of the presentation. Today, our speaker is Dr. Jennifer Goralski, joining us from the University of North Carolina at Chapel Hill to give a talk on Beyond FEV1. Dr. Goralski is the Associate Director of the Adult Cystic Fibrosis Center and Assistant Professor of Medicine and Pediatrics at Chapel Hill. She completed all of her medical education and training here at what used to be UMDNJ, then went on to complete a combined Med-Peds Plum-Crit Fellowship at UNC. As a physician scientist, Dr. Goralski has led multiple grant-funded research initiatives and clinical trials, including the development of novel outcome measures for evaluation of cystic fibrosis lung disease and the different imaging modalities to do so. Dr. Goralski has also been awarded by several professional societies, including the Cystic Fibrosis Foundation, with the Leroy Matthews Physician Scientist Award, and the Program for Adult Care Excellence Award. We welcome you and thank you, Dr. Goralski, for joining us today to give this presentation.
Well, thank you very much for that kind introduction. Let me just get myself into slideshow mode. It's good to be back home, even though it's virtual this time, but hopefully in the future it can be in person again. But I did recognize some familiar names coming across the screen, so that's exciting for me. I'm going to talk about my research in the context of cystic fibrosis, which is really what I've spent the majority of the last 10 years focused on. And it really provides a framework for why I came to be fascinated with this particular area of research and how we're moving forward with pursuing additional understanding of how to visualize ventilation. Hopefully my slides will advance. So as requested, there's the CME information. It will also be on again at the end of the talk. I have several disclosures. I do receive grant funding from the CF Foundation and the National Institute of Health, which supports the work that I'm going to show you towards the end of this presentation. I also receive funding for clinical trials and for scientific advisory committees, which have been carrying on this talk. So cystic fibrosis was first described in 1938 by a pathologist named Dorothy. The actual original name of the disease was cystic fibrosis of the pancreas, because what they found were that these children were dying before age 10 for the most part from really malnutrition-related disorders. It was related to the fact that they were severely insufficient. And so the pancreatic manifestations were known well before the lung manifestations were understood, simply because the children didn't live long enough in order to be able to develop much in the way of lung manifestations. But now we know that CF is really a multi-system disease, and the primary morbidity and mortality is really related to the pulmonary findings of bronchiectasis and pneumonias, ultimately leading to respiratory failure. But I can diagram to read every single box on here, but there are a host of manifestations that really does multidisciplinary approach in order to be able to treat this disease, which is why I particularly enjoy pulmonologist training. I get to think about these other organ systems in some detail as well. So a little bit about the basics of CF and the genetics associated with it. So CF is caused by a genetic mutation in the CFTR gene, which then leads to an abnormal CFTR protein. And this protein is responsible for conducting chloride transport in all the epithelial cells of the body. And so with a malfunctioning or an abnormal CFTR protein, we get defective ion transport, which then leads to airway surface liquid depletion. So essentially, if you are unable to move ions along their osmotic gradient, the water doesn't follow as well and your mucus gets thick and sticky. This leads to defective mucociliary clearance and then mucus obstruction, infection, inflammation, and scarring in a chronic cycle of destruction, ultimately leading to end-stage lung disease. This is a little video. There's no audio to it, so I'll narrate through it, but it's a little video put together by the CF Foundation that just shows you graphically that cycle of destruction. So this is a close-up of the epithelial cells with the cilia beating along the surface, moving particles of mucus along. And this is an example of what a CFTR protein might look like with the chloride ions flowing through. Now, in the absence of functional CFTR, where chloride cannot flow through down its appropriate osmotic gradient, what happens is that mucus is no longer hydrated well. It gets thick, sticky, and it actually collapses down on top of the cilia so that they no longer beat well and move mucus along. And this serves as the nidus for infection, which propels most of this destruction in the lungs and elsewhere. So we do have several different ways that we could try to address the cycle of destruction. Ultimately, once we get to end-stage lung disease, lung transplant is an indication for end-stage lung disease due to cystic fibrosis. Hopefully, we hope to avoid getting to that point. Within the cycle of mucus obstruction and a defective mucociliary clearance, we can treat with medications to help break up DNA bonds within the mucus, mucolytics, inhaled antibiotics, airway clearance techniques that forced mucus to be moved along in the lungs, and even anti-inflammatory medications. Try to restore the airway surface liquid layer. We can treat with osmotic agents such as mannitol or inhaled hypertonic saline to force hydration of that defective mucus layer. Where the most interest has been recently has been in the area of CFTR modulators. And this is really trying to get at the genetic defect and targeting that protein that is malformed so that we can conduct ion transport effectively. And finally, our holy grail, what we're working towards now is in gene therapy, either DNA or RNA editing, so that we can actually get in and fix the genetic defect before we start the cycle of destruction. This is an old slide by now, but it was created back when the first CFTR modulator was approved. And this just shows on the left hand side of the screen the median predicted age of survival in years and over the decades of CF care and research. And so as we instituted various types of different treatments, we could see the median age of survival gradually increasing to the point where we were just under 40 years of age for median age of survival at the time the first CFTR modulator was approved. And much of this is due and thanks to the Cystic Fibrosis Foundation. Now, this was a parent-initiated organization that started in the 50s, and it was, again, founded and run by parents who were obviously devastated at their children suffering from this horrible disease. And so they decided to band together and create a foundation to support research into this orphan disease. And the name 65 Roses it comes from a little boy who overheard his mother talking and trying to fundraise for this particular disease. And he didn't know what diagnosis he had. And when he heard the term cystic fibrosis, he thought his mother was saying 65 roses. And so 65 Roses has become the symbol for the CF Foundation. And it's still going strong, almost half a century later. The CF Foundation really serves as our touch point and our approving agency in some senses. We have a large patient data registry that we insert information into on an annual basis about all the patients that we care for, and that allows us to provide really good quality improvement within our own center and then also nationally, as well as conduct studies that would not otherwise be able to be done in a disease that really only affects about 30,000 patients in the US. So this is a map of our CF Care Center network across the U.S. And so the CF Foundation accredits different care centers. So there you guys are. You obviously have quite a bit of CF in your neck of the woods. I'm down here in North Carolina. The size of the dot corresponds to the number of patients that is the population served within that area. And so there's obviously sites with larger catchment areas and then sites with smaller ones. But over the years, CF has really become a disease for internists, and that's actually what piqued my interest in it way back when I was doing my med-peds residency, was that there was a growing number of adults with cystic fibrosis, and the adult pulmonologists were not necessarily familiar with it because most of the time, when these folks were in training, these children had died before reaching adulthood. And so it was a great field for me to step into. And you can see that over the years in the 90s into the 2000s, we've had the number of diagnoses of pediatric patients being about the same. It's pretty flat there. But overall, our population has increased from the vast majority due to people living longer into adulthood. And we finally, a couple years back, crossed that median threshold where there are now more adults with CF living in the United States than there are children. So these are the new faces of CF. These are the patients that we take care of. Not quite the same malnourished looking infants as in Dr. Anderson's first paper, but we expect them to live healthy, active lifestyles and to achieve the goals that they set out for themselves. So I'm going to talk a bit about CFTR modulation and the correctors and potentiators. And again, thinking about this from a genetic perspective, CFTR is a really interesting protein in that it has several different mechanisms for which it can become abnormally functioning. So we'll start off with class number one. Class number one is it's a scenario where there's no CFTR made. So these are scenarios where there's a stop codon, or the protein is otherwise truncated or simply not made at all. And this is obviously a quite severe mutation since there's no CFTR protein to be made. The class 2 mutations contain the most common mutation in CF, which is the F508 deletion. And in this scenario, a CFTR protein is made, but it's abnormal, it's misfolded, and it doesn't actually reach the cell surface in order to be able to act as an ion conductance channel. Classes 3, 4, and 5 are what's considered to be the more mild mutations, if you will. So in these various mutations, some degree of CFTR protein does reach the cell surface, but either it doesn't open at all, it opens as a channel, but not enough to allow for enough chloride ions to flow through, or there's simply not enough of it made. And so there's a deficiency of CFTR at the cell surface. So this really drives how we address these various classes of mutations. The first one is kind of the hardest and is the one that we're looking to gene therapy for, because if there's no CFTR made, you have a nonsense mutation, then there's no modulator that you can create to work on a protein that's not being made. But we can work on class 2, and in fact, quite effectively now. We have drugs that are called correctors paired with potentiator drugs that essentially rescue that mutated CFTR protein, teach it to refold and reach the cell surface, and then force it to stay open, so force it to function. And so this combination of correctors and potentiators is helpful in these class 2 mutations. And in class 3, 4, and 5 mutations, you don't even need a corrector because there's already some protein at the cell surface. You just have to make it work better. And so these mutations are somewhat simpler to address with just a single drug. But here's the challenge, is that there's over 1,800 known mutations that cause cystic fibrosis. Now, the vast majority of people with CF, nearly 85% of them, have at least one copy of the F508 deletion mutation. And so that's the large majority of patients. But you can see that the next most common 24 mutations, we're talking about really, really small percentages of the patient population that have one of these mutations, which makes studying them both in vitro and in vivo really challenging. Despite that, we do have 4 currently clinically approved, FDA-approved CFTR modulators. These are synthetic, orally active, either potentiators or potentiator and corrector combinations of CFTR. And they've really been shown to markedly improve quality of life in CF, as well as lung function and body weight. And so starting with ivacaftor, which was approved in 2012, it was actually approved initially, and only about 4% of patients with CF would benefit from it at the time. It was only approved for those class 4 mutations. But since then, over time, we have both extended the age range down. So now patients as young as 4 months are eligible for treatment with this drug. And it includes up to 97 gating and residual function mutations that are much rarer within the patient registry. And then the most recent approval was in 2019 of elexacaftor, tezacaftor, ivacaftor, or ETI, we call for short, which has now been approved down as young as the age of 6. And it is approved for anybody who has at least 1 copy of F508del or one of 178 other minimal function mutations. This is just some of the robust data from the initial study in the New England Journal that led to or helped lead to the approval of this drug. This is pretty robust. You don't see this in clinical research very often. And so really exciting for all of us who work in this field. So over here, this graph on the left is showing us the percent predicted FEV1 over the 24 weeks of the study. The gray line is our placebo patients, and the blue line is the patients who are treated with ETI. And this is an absolute change in baseline in their percent predicted FEV1. And so within 2 weeks of starting the drug at the first visit, they had an absolute improvement of about 13% improvement in their FEV1, and that was sustained over the course of the study compared to the placebo group. And even more fascinating was the concept that we could get at this genetic defect and actually affect the sweat chloride values, which were our diagnostic means. And so in general, the patients who were on placebo, they measured their sweat chloride levels at various time points during the study as well. The patients who were on placebo stayed the same, which would be expected, but the patients who received active drug had a drop of 40 millimoles in their sweat chloride concentration, which actually brought many of them down into the non-diagnostic range for CF any longer. So we know that lung disease begins early in CF. There are longitudinal studies mostly coming out of the Australian groups where they study these patients from birth with annual CT scans. And they found that bronchiectasis is present in 30% of infants who are 3 months of age, which is incredible because most of these 3 months old, we have no idea clinically looking at them that there's any sort of lung pathology going on. And by the age of 3 years, over 60% of people with CF will have CT evidence of bronchiectasis despite not having any symptoms. And so when you're looking at a parent and you're saying, hey, you know, like we need to think about starting a medication or doing this to your child, and they're looking at this happy, healthy, bubbling little baby who is, you know, requiring some pancreatic enzymes, but that's it. It's really hard for them to accept this concept that there could be an ongoing cycle of damage in their child's lung that we can see no sign of clinically. And so the question arrives, can we achieve more by treating younger patients? And I think that the answer clearly is yes. If we can stop that cycle of destruction earlier on, the likelihood is that children who are growing up in this day and age with earlier access to modulators are going to have much more mild pulmonary disease moving forward. We know our fight is not over despite this, these really remarkable medications that have been approved recently. Because about 10% of people with CF don't qualify for any of the current approved modulators. These are mostly patients that fall in the class 1 type of defect. There are, of course, side effects. The major one that we deal with is with liver inflammation, and so we have to monitor that regularly. And of course, one size doesn't fit all. Not every patient responds to the same drug in the same way. Not everyone has achieved that 14% improvement in FEV1. Patients are starting treatments with different baseline levels of disease. And so how somebody who it progresses if they start in an FEV1 of 40 versus an FEV1 of 100% predicted is going to be very different. We don't know our long-term outcomes. Obviously we have about 10 years of experience or longer, including the clinical trials, but we have much experience now with Kalydeco, but not necessarily with the ETI. And then importantly, thinking about this as a global disease, there's about 30,000 people with CF in the US, but about 70,000 people worldwide. And the entire rest of the world is not completely convinced about the cost benefit ratio of these types of medications. And so we are going to continue to see different levels of disease in different parts of the world. So this led me into my particular area of research, which is really focused on defining clinical trial endpoints. Understanding that research is still crucial. We still need to understand how our patients will progress and what types of therapies are best for the right type of patient. So I'm going to deviate just a little bit and talk about defining clinical endpoints in clinical trials. This is a fantastic paper cited down here. It really goes into great detail about the difference between efficacy measures and surrogate endpoints. And I've referenced back to it a number of times over the years. But a clinical efficacy measure is the FDA gold standard for clinical trials. If you're conducting a clinical trial of a new therapy in a patient, your efficacy, your evaluation of how your drug works needs to be based on a characteristic or a variable that reflects how a patient feels, functions, or survives. And so some examples of this, within cystic fibrosis, we can talk about hospitalizations requiring IV antibiotics. That certainly affects how a person feels and functions, or COPD exacerbations, or patient-reported outcomes. That clearly reflects how a patient feels. The challenge with most of these, though, is that it requires really large clinical trials in order to be able to see statistical differences in these. Large trials over a number of years, particularly, I didn't show you the data for pulmonary exacerbations with a triple combination therapy. But if we reduce the number of pulmonary exacerbations, hey, that's a great thing. But then how are we going to evaluate other types of therapies that are going to come along the pipeline if we no longer have reasonable access to this as a clinical efficacy measure? So the FDA also accepts surrogate endpoints when considering approval of new drugs. And a surrogate endpoint is a lab or a physical exam sign that's used as a substitute for a clinically meaningful endpoint. That is a direct measurement of how a patient feels, functions, or survives. And importantly, it's expected to predict the effective therapy. So an FEV1 falls in this category, and this is what the CF community has long depended on, is that we expect that an FEV1 that is lower, if you're able to improve it with therapy, that should improve how a patient feels, functions, or survives. However, it is a surrogate endpoint because an FEV1 of any particular value does not predict exactly how that particular person is going to function. For example, I have a patient I've been taking care of for over 10 years now. He's in his early 40s and his lung function is 13% of predicted. And if you had asked me 10 years ago, I never thought he would have survived until now, especially through COVID. But he still functions relatively well. Now, you take any one of us and you give us an FEV1 of 13% of predicted, we're likely going to feel pretty crummy. And so overall, as a global measure, FEV1 tends to be fairly reliable, but on a single patient-by-patient basis, it is a surrogate endpoint and not a clinical efficacy measure. So what makes a good clinical trial endpoint? Well, it's got to be clinically and biologically relevant. It's got to make sense in the context of the disease. It has to be sensitive and specific to treatment effects. And so as disease progresses or as disease is treated, your outcome measure has to be able to pick up on those changes. It has to be reproducible. So you have to be able to take somebody and do the test and get one result, and then do the test again a week later and a month later and a year later. And if nothing else has changed in the context of the disease, you should get a similarly reasonable measure. And an outcome measure has to be feasible. People have to be willing to do it. Bronchoscopy is a very useful tool in the pulmonary field. Is it a feasible measure for clinical endpoint trials? Not in a lot of cases because of the invasiveness of it. And so it's got to be something that both sites can do and that subjects would be willing to participate with. This was actually in the news quite a bit recently. You may remember hearing a few months ago about the whole debate regarding the FDA approval of the Alzheimer's drug. This really highlights that difference between the clinical efficacy measures and the surrogate endpoints, in that this new drug was shown to reduce the plaques in the brain, which was a surrogate endpoint measure, but that had never actually been tied to how a patient feels, functions, or survives. And so there was a lot of debate about this and whether or not the FDA should have approved such an expensive medication without overt measurement of patients actually feel better or have improved functioning on this drug. So then the question for me and my colleagues becomes, in the era of highly effective modulator therapy, so things that improve those FEV1s and improve those sweat chlorides and improve those hospitalization rates, how do you best detect and monitor mild CF lung disease? So we have a couple of tools. I think most people are familiar with spirometry, where you take a deep breath in and blow all the way out as a forced exhalation, and we can measure that FEV1 that I was talking about before, the forced expiratory volume, in 1 second. But as I've shown you, we're expecting that there's going to be less and less sensitivity to disease with that, and particularly in young children who cannot perform this maneuver, or in patients with fairly mild disease. Their disease might have already progressed before you actually see evidence of it on their FEV1. We can also measure something called multiple breath nitrogen washout. Now, this is mostly a research tool, though it's slowly making its way into a little bit of clinical practice here and there. This is another measurement of lung function that essentially measures the number of lung turnovers that are seen when someone is breathing 100% oxygen. So we have the patient hooked up to a mask. They're doing simple tidal breathing. We are calculating the percent of nitrogen in their exhaled breath. And then we give them 100% oxygen. And the concept is that as you breathe in 100% oxygen, eventually the air that you're breathing out is going to have less and less and less and less nitrogen in it, which is what we see over here as the concentration of nitrogen moves downwards. And so the lung clearance index, or LCI, is defined as the number of lung turnovers that it takes for somebody to drop their nitrogen concentration to 1/40th of the original starting concentration. And so we can essentially say, how many lung turnovers does it take for them to completely wash out their lungs. So this technique, again, mostly research-based now, but is really gaining a lot of ground in CF research, particularly in mild lung disease and in children, because it doesn't require active cooperation. We can do this on preschoolers with pretty reasonable results. We can also measure lung structure. A chest X-ray is currently recommended by the CF Foundation for annual evaluations. But the reality is that until your lungs actually look this bad, you don't have a lot of sensitivity and specificity to disease in CF. Your chest X-ray is not the end all and be all for diagnosing or deciding to make treatment changes. Now, chest CT can be a lot more helpful. It's broadly available. And in fact, in Europe, they have routine use of chest CTs, and more than 50% of the centers report that they have annual or biannual use. And there's been some interesting improvements in CT recently in various types of techniques where you can quantify small airways disease by co-registering inspiratory and expiratory images and calculate out actually air gas trapping based on CT findings. But the real downside of CT is the ionizing radiation effects. And if we're talking about a relatively young population in CF, infants, children, young adults, we obviously don't want to do an outcome measure where we're going to be subjecting them to repeated courses of ionizing radiation. So last year, the CF Foundation hosted a virtual workshop to talk about the fact that, hey, we're all really excited that we have access to these great new modulator drugs. But as a community, we really need to think about how we're going to be able to continue to detect and monitor mild CF lung disease. And so our key points were to identify novel and developing biomarkers that could serve as surrogate endpoints. We wanted to make sure that there was standardization across the sites and create these data repositories, because there's a wealth of information here that we have to be able to share in order to get the best benefit out of it. And we love the idea of leveraging free data from surrounding tissue. So if you're going to do a CT scan on the chest, yes, you're doing it primarily to look at the lung parenchyma, but you'll also see a view of the muscles, for example, and can you develop a measure looking for sarcopenia as a measure of frailty within the already clinically obtained CT scan? And then finally, we could incorporate artificial intelligence to remove the human factor from this so that we can ensure that our endpoints are standardized and repeatable across sites. So MRI was a big topic of discussion. And if you're like me, you were probably sitting there scratching your head and saying, MRI really for lungs? I thought I learned in medical school that MRI wasn't good for the lungs, right? Because you need to have different changes in the density of tissues in order to be able to pick up anything on MR. But there's been a lot of improvements in MR over the last 20 years or so, and sequence development and such that you can see here, this is just a snippet I took from PubMed when I was doing a search for just pulmonary MRI. Over the years from 1984 to 2021, there was 638 results for pulmonary MR. And you can see the really robust in the last decade or so, a lot of papers coming out regarding how we can use pulmonary MRI as a useful tool for both clinical and research purposes. And these are just some of the key papers that I had noted. And so within the context of CF, they have used pulmonary MRI to detect structural abnormalities in preschool children, like we talked about for CT scan. We have found that MR correlates with high resolution CT scan findings, and that it is responsive to changes in disease state, such as pulmonary exacerbations. So it's an intriguing concept. And in fact, even the Fleishner Society recently put out new guidelines suggesting that there is enough data to support current clinical application, not even research application, but clinical application in the context of CF, lung cancer, and pulmonary hypertension. And they note that proton MR provides morphological information with respect to mucus distribution, bronchiectasis, inflammatory wall thickening, consolidation, atelectasis, and depicts disease activity from birth. And so with this being said, with this guideline paper having come out recently, I do think that we're going to see a lot more of this from a clinical side of things as well. So there are a number of different scoring systems because, pulmonologists, we like images, but we also like hard numbers that we can crunch and compare. And so the groups in Germany have created the scoring system that's probably most widely used. Where they break down the lung into the right and left and then the various lobes, and they score these different types of parameters. And the higher the score, the worse the amount of, or the presence of disease is. And so with a global maximal score of 72 based on this assessment. So this is one of the early papers that looked at this particular scoring assessment. They looked at 40 children with CF. They were between the ages of 0 and 6, and then they compared them to healthy controls as well. So this is the data just from the CF patients. But within that 6-year age span, they had under 10 subjects in each of those categories, but totaling 40 patients. Look at the prevalence of disease that they were able to find in these young children. And then comparing them to healthy controls, there was significant difference in the children with CF. And personally, as a non-radiologist, I personally feel that sometimes the techniques get so progressive that it can almost be hard to tell the difference between a CT scan and MRI when you're just looking at the images. That's how great these UTE or ultra short echo time images have become. So this is a recent paper coming out of CHEST. These ABC images across the top are all pulmonary MRIs with the ultra short echo time sequencing, and then comparing to similar cuts on a CT scan. And even though the data quality is slightly different, you can see that you don't actually lose any of the hallmark findings, right? We still see areas of saccular bronchiectasis that we can compare side by side, pleural thickening or nodules that they're pointing out here. In the sagittal view, we can also see airway wall thickening and bronchiectasis. Mucus plugging is visualized in both of these different scenarios. And so even though the images might not be as sharp and pretty to look at compared to CT, if you can find the same findings and you're eliminating the need for ionizing radiation, it's a go. So we've all seen pictures like this before. What you're looking at depends on whether you're looking at, your eyes are focused on the black or the white area. And that concept really drives the idea behind hyperpolarized gas as an inhaled contrast agent. This is my only physics slide, and I'm not going to run through it entirely, but just to point out that the signal quality in magnetic resonance imaging is really determined by the number of nuclear spins that are aligned in either direction. And so if we can apply a force that allows us to align more spins, then we can get a better picture. And then as those spins unalign. And so we do this by a process called hyperpolarization, which applies taking angular momentum and using a technique called optical pumping with a rubidium ion and allowing that to exchange its spin with a non-polarized gas and make it hyperpolarized gas to allow more of those electrons to be aligned in this nuclear spins to be aligned in the same direction. And so if we give someone an inhaled hyperpolarized contrast agent to breathe, this is that sort of negative reflection image that you can see. This is a series of images going through from anterior to posterior all the way back here, and really fine, exquisite detail, both of the tracheobronchial tree and of all the different, or within the pulmonary parenchyma. And so combining hyperpolarized gas with ultra short echo time MRI to get at the structural deficits can really give us a good combined structural and functional picture of what's going on in the lungs. So for example, here is this is prior to UTE imaging. So this is just standard proton imaging in MR. And it's just a single section of a patient with COPD, right? So we can see the tissues, they're all different densities, and the lungs are kind of, blasé. There's not a ton going on here, maybe some increased markings down at the bases, but overall not too much to write home about in this patient with COPD. But if you have them inhale a hyperpolarized gas, and obviously this gas is in post-processing tinted green so we can see it more easily, the gas does not fill this entire portion of the lung. And so this patient had a very large non-communicating cystic lesion or multiple cystic lesions here for which the gas was not able to get to, and therefore this entire portion of the lung is not contributing to gas exchange.
And you wouldn't have necessarily known that by looking at just the straight proton imaging. There's a smaller area of ventilation defect here, and what the teams have been working on is how to categorize and quantify these ventilation defects, and they ultimately call it something called a VDP, or a ventilation defect percentage. So I have the total lung volume based on the expected volume calculated from the anatomic image. What percentage of the lung is or is not involved in gas exchange? So recall we talked about what makes a good clinical trial endpoint, right? We need it to be clinically and biologically relevant. We need it to be sensitive and specific. It has to be reproducible, and it has to be feasible across different sites. So does hyperpolarized gas meet this definition? And the answer is, I think it's getting there, if not there yet. And the Fleischner Society, when commenting on the pulmonary MRI, they said that there's clearly evidence for proton MR, but so far hyperpolarized gas is still within the research realm. So this is an example of an adolescent who was having a CF exacerbation, and he had a hyperpolarized gas MRI done before his when he was acutely ill with his CF exacerbation. And just to remind you down here, this is what we're expecting to see, this nice kind of homogeneous filling of the lung. And here in this patient with CF, very large ventilation defects, right? Areas where the gas just simply doesn't get to. And then they treated him with IV antibiotics, and this is this bottom panel down here. So obviously he still has a really fair bit of disease, but now we can directly compare that there are areas which were not ventilated before that are being ventilated now. And so this is a mechanistically appropriate concept for drug-related trials. If we can see changes this quickly, it stands to reason that this could serve as a good surrogate endpoint. And in fact, there's lots of people who agree with this, so much so that there's been a clinical trials consortium that's focusing on hyperpolarized xenon that has sprung up over the last couple of years. And this star down here is actually Duke University, is not UNC, but I think that they are nonetheless doing good work, even though we're not part of the consortium. They are publishing papers that are looking at protocols for multi-site trials, because that's really the key, right? A single center trial doesn't help a lot of people, but a multi-center trial, if you can standardize and get the same site to perform the same technique, and we can really enroll a variety of people, that's how we're going to get to better clinical outcomes. And in fact, that they are actually studying hyperpolarized imaging in new treatments, so particularly within this LX catheter, TEAS catheter, IVA catheter for CF patients. And so it's national and international consortium. Just one example of one of their recent studies. They had two sites performing the same hyperpolarized gas with the same sequencing and techniques, and two analysts at each of the sites. And so that both analysts analyzed both sets of images, and they calculated out a ventilation defect percentage for each of these patients and healthy controls versus CF patients at each of the sites. And there was pretty good agreement overall that the purple areas here are the ones that they depicted as their ventilation defects. And then the analysts compared the healthy to CF or healthy controls to CF patients at the sites, and found significant differences between healthy and CF. And importantly, there was really good intra-observer agreement, right? So that's key, that different people are evaluating these things as quite similar. So all that being said, the research that I've been focused on over the last several years is actually using a different gas called perfluoropropane, or PFP. PFP is a commercially available gas that we study under investigational new drug agreement from the FDA. but the fact that it's available commercially allows us to do dynamic imaging. So with the hyperpolarized gas, because of the amount of work that has to go into the hyperpolarization and the really short half-life of the hyperpolarized gas, essentially now they're limited to single breath inhalations. And so they're doing one breath and looking for these ventilation defects. But what our group was considering was that that's not how our lungs function on a regular basis. We breathe multiple times every minute. And so we were interested in looking at a gas that we would be able to administer and actually do a dynamic multi-breath protocol to look to see what the true ventilation defects are. And this particular gas has lower capital and operational expenses than other hyperpolarized gas. And the most important thing is that you can easily modify your current multinuclear MR scanner in order to be able to use this technique. So it is translatable to other centers. This is my research coordinator lying in the bed of our MR, getting ready to go in and pretend to have a scan. And so just to show you, orient you how the patients are situated for the procedure, they lie on the MR bed. This is a 19F or a PFP tuned chest coil that is wrapped around their chest loosely, and it allows for the MR to detect that particular 19F signal as opposed to the proton signal that it's used to detecting. We store the PFP in this bag, and it's linked up to the patient who's wearing a CPAP mask. And so they have a one-way inspiratory and then an expiratory valve. And so we can, from the back room, we can turn them over from breathing room air to PFP and back and forth so that we can measure both inspiration and expiration. And importantly, our PFP gas that we purchase is commercially available. And so it's a mixture of 21% oxygen and 79% PFP. So we don't have to worry about hypoxia. Being cognizant of the time, so I'm just going to go through this a little bit quickly. So gas wash in and wash out. So we basically take an image after a tidal breath and then a single large breath and breath hold. And then we image on that breath hold, and we can watch as gas washes in and then also as it washes out, and we repeat until there's no gas available. And so what that allows us to do is to take any single voxel and measure its intensity over time so that we can get at a good estimate for the time constant for gas wash in and wash out, and think about these voxels not as purely ventilation defects, but as slow emptying or slow filling voxels. And so here's an example of slow emptying in this patient with moderate CF. You can see compared to the healthy patient who enters really quickly, the patient with moderate CF takes a lot longer to empty the gas out of their lungs. So we looked at this initially in 14 patients who are healthy compared to mild to moderate CF, just simply defined by an FEV1 of greater than 80%. And when we started just looking at the ventilation defect percentage, just to see if we could compare to the hyperpolarized gas, we did see that yes, in our patients with mild CF, even though they have a relatively normal FEV1, there were still fairly large ventilation defects. This patient with moderate CF with an FEV1 of 42%, which happens to be my clinic patient, and she has essentially no right lung, very large ventilation defect on that side. But then moving to capitalizing on this dynamic data acquisition, it turns out that if we look at this portion of that signal intensity curve with the gas washout, and we compare the mild, moderate, and healthy patients, we can see a difference between these gas washout time constants that distinguishes between the severity of disease. And I'll skip this just in the sense of time, but we have come to the conclusion that the fractional lung volume with a slow gas washout time was able to sensitively detect between healthy, mild, and moderate CF lung disease. So then we compared F19 gas to proton to hyperpolarized gas MRI just to see if we're seeing the same types of ventilation defects. Now it's really hard to compare a dynamic sequence acquisition to a static sequence acquisition. And so what we ended up doing was taking the final breath of PFP and comparing it to a high resolution CT scan, and then filling in this ventilation defects over here to compare them directly. And so it's interesting what we found, and we're curious to look into this again in the future. But we had a lot of areas that were matched, right? So areas here, like in the blue, where they had the presence of both xenon and F19 gas present on both images. Okay, so those are matched areas that ventilate well. And then in the green over here, we have areas that are clearly ventilation defects. Neither xenon nor F19 gas gets to that area. And so these are clearly areas that are not participating in gas exchange. But what was a little more difficult to understand were these areas in the purple and the yellow, where there was either the presence of F19 but the absence of xenon, or the presence of xenon and the absence of F19. And so what we discovered by looking at the gas wash in and wash out curves was that these are the areas that are really characterized by the slow filling and the slow emptying compartments. And so it really breaks down the idea of this ventilation defect as not just a single static thing, but that there are areas that the entire lung is not one black box, that every single voxel or alveoli does not ventilate at the same rate. This is one of our subjects who doesn't seem to mind undergoing the study and has done it a couple of times over the past 15 months. And just to get an idea of whether or not we can achieve that reproducibility and changes responsive to disease state, we've studied her in a stable and in a disease exacerbation over a 15-month period. And what I really think is important here is looking at visit 3 when she was stable after she had recovered from her pulmonary exacerbation. Her FEV1 had nearly recovered to baseline of 73%, but her fractional lung volume with slow gas washout time was still higher than before, as was her ventilation defect percentage. And we can see that here on the right upper lobe, we don't quite get the same amount of filling that we had before. And then finally, the most recent study that we've done is looking at a small number of patients before and after starting elexacaftor, tezacaftor, ivacaftor. Now, the study was smaller than I would have liked because this drug was approved in October of 2019, and we all know what happened in March of 2020. And so the recruitment was stymied, of course, by that. Because of the robust clinical response to this drug that we saw in the clinical trials, there were a big excitement to try to get a lot of people on this drug quickly. So we ended up with only 8 patients enrolled in this pre-post study after 1 month of ETI. But we looked at the things that they had looked at in the clinical trials, FEV1 and LCI, and we did see a significant improvement in both of those. And then we looked at both our structural scoring changes in the UTE-MRI as well as the 19F MRI. And we're gratified to see really nice improvements in both of these as well, which is, I think, highly significant in the fact that bronchiectasis has always been thought to be irreversible. And yet here we are after 1 month on ETI, and the bronchiectasis subscore on these MRs is showing improvements in these patients. So to summarize, I think that new surrogate endpoints for clinical trials in lung disease are urgently needed, particularly in CF. And I hope I've convinced you that advanced imaging techniques may serve as biologically plausible, reproducible, and sensitive markers for clinical trials of obstructive lung disease. Team science is critical. And I obviously couldn't do this without my colleagues in physics and radiology and biomedical engineering. And so I work within a wonderful group of people. And with that being said, here's your CME information one more time, and I'd be happy to entertain any questions. Thank you so much for your attention.
Goralski, hi, thanks so much for a great talk covering multiple issues in CF, starting off with just reviewing where we are in CF and some of the underlying pathophysiology, the genetic abnormalities that are complicated and complex. And then this really interesting discussion about surrogate markers and clinical outcomes, and the disconnect that sometimes exists in trying to ensure that we're really talking about the same thing when we're using surrogates and their utility in treatment, which is really critical to ensuring that they are reliable. So thanks for all of that. A lot of interesting issues. So let me just first, if people have any questions or comments, please obviously either raise your hand or come to the chat box or speak up. But while we're waiting for that, let me just go back. It's fascinating. You showed this differential between the hyperpolarized gas and the PFP. And some areas there of lung where one appears or not, or the other appears. What do you make of that? Why is that happening, and what are the insights to be derived between how these gases then work as it relates to cystic fibrosis?
Yeah, it's a great question, and it's one that we don't have a clear answer to yet. But the density of the gases are different, right? And so the PFP gas is much more dense than the hyperpolarized xenon gas. And so in terms of the time for wash in, there is a difference there, which is why we couldn't compare direct, single breath of PFP versus single breath of hyperpolarized xenon. But it's actually really interesting because what we were able to do was, even though we compared the final breath image for both of those different gases, what we were able to do with the PFP gas, since we had the dynamic data sitting there, was we looked at, for each of those areas of the unmatched defects, we looked at the rate of gas wash in and wash out. And so what we found for the areas that where there was the presence of PFP gas at the end image, but not the xenon gas, those were really actually areas of slow gas wash in. And so theoretically, given enough time breathing the xenon gas, those areas would have filled, maybe by collateral ventilation, but we wouldn't have dismissed them as total ventilation defects just based on the single breath image. Now, the other one was a little bit harder to explain because you wouldn't imagine that a single breath of xenon would necessarily show you gas in an area where multiple breaths of PFP weren't. But our supposition for this was a little bit different. It's actually interesting. Remember I talked about the xenon and how quickly or how short the half-life of it is. Well, xenon actually degrades really fast in the presence of oxygen. And so we had a concept that those particular areas that were highlighted really densely, a really strong signal intensity with the xenon, those are voids where there is actually little ventilation going on with, and the presence of trapped gas in that area and the lack of oxygen really contributes to the decrease in breakdown of the xenon gas in those areas. So I think it's something interesting to be explored. I think that the concept that we're really trying to take home is that the ventilation defects that we see on dynamic versus static imaging are not equivalent, and it's probably going to be some combination of the different types of techniques to determine what is truly reversible ventilation defects versus permanent.
That's very interesting. It'll be interesting to see about response to therapies and how that plays out in that regard, and whether the PFP is more sensitive. It'll be interesting to see that. A question, Dr. Bleich, regarding the FDA's guidance for using these new MRI techniques as study endpoints. Where is that?
So we're moving towards that direction, hopefully. I haven't had any success clinically here. It's all still research-based. My hope is that, and this is one of the things that we talked about at that imaging summit, is that we need, with the Fleishner Society paper coming out and more clinical trials using MR as an imaging endpoint, we do think that there is going to be a push for FDA approval and thus insurance approval for imaging to look at both dynamic disease and in treatment options. One of the hyperpolarized gas companies made an application to the FDA back in October for a drug device combo that was using their polarizer plus the polarized gas to get FDA approval. And it wasn't approved on the first round. I believe they're going back with a regroup in a little bit. But I think that once we do get that FDA approval, you'll see it become much more clinically mainstream.
Thanks very much. Just a quick question, if anybody else has, but just a quick question on the genetics that you showed. Are all of these spontaneous, polymorphisms or deletions or nonsense mutations? Are they? What's the inherited base of any of this, or is there any?
I'm sorry, say that again.
The genetic bases, they're all spontaneous.
They're inherited. Yeah, they're inherited, and CFTR is a complex gene with not just mutations of known clinical significance. Like I said, there's about 1,800 of those that are known clinically responsive mutations, but there's also an increasing number of mutations of varying unknown significance. And so, since we've been able to sequence the CFTR gene, we're able to detect all these different types of genetic mutations. And some of them we don't know what to do with. And there's actually this growing number of patients with a diagnosis of something called CRMS, or CFTR related disorder, which is where we have a mutation in the CFTR gene and we have no idea yet if it actually means anything or if it leads to clinical disease. And try to explain that to a parent, right? We're like, well, your test was abnormal, but we don't really know what that means. And we just follow them clinically. But no, it is inherited traits. Yeah.
Thanks, Dr. Goralski. I'm sorry our time is up. I want to thank you for a wonderful talk. It is great to see one of our own doing so terrifically well. And thank you for visiting back with us. That's really a great treat. I want to thank everybody for joining this morning and hope everybody found this very informative and very, very interesting and enjoyable presentation. So wish you all a great rest of the day. Thanks again very much.
Thank you.